Hi, thank you for joining us today. This is the third webinar in our three-part series on hepatitis C. The topic today is going to be hepatitis C post-treatment, key topics for consideration. And these webinars are brought to you by way of the Michigan Opioid Collaborative. These are the disclosures. Funding from the Michigan Department of Health and Human Services through a grant to the Michigan Opioid Collaborative funds this program. And the objectives today are really going to be threefold. So in the first part of these three webinar series, we discussed the epidemiology and screening and link to care for patients living with hepatitis C. The second webinar, we focused on hepatitis C treatment. And so today the objectives are going to really be on number one, discussing post-treatment considerations, two, discussing hepatitis C and pregnancy in more detail, and then finally also describe the clinical management of hepatitis C and B co-infection, as well as reactivation. So we'll start with just highlighting some of the post-treatment considerations we should all keep in mind after we've moved a patient and through treatment and accomplished a cure. That before we embark on treatment, we do a fibrosis assessment, and this is covered in the first two webinars. And what we really want to know is if any of the patients that we are managing and treating for hepatitis C have advanced liver disease, or what we call cirrhosis, prior to treatment. And that's obviously important for treatment selection to a certain point, but also really for monitoring them post-treatment. And the reason for that is because of HCC, or hepatocellular carcinoma risk. So patients with cirrhosis are at risk for developing liver cancer or hepatocellular carcinoma, and therefore need to be monitored long-term and screened, if appropriate, for liver cancer. And the second part of this, in terms of post-treatment considerations, is that there's always a chance for reinfection if the risk of ongoing exposures still exist in a given patient. And this was covered in the second of these three-part webinars. And so it's recommended that patients with ongoing exposure risk are monitored after they're cured every 6 to 12 months based on the various societal guidelines. And then in those patients who have no ongoing exposures or risk for reinfection with hepatitis C, annual ALT monitoring is what is recommended at a minimum. Some providers might opt to choose to monitor for a Hep C RNA if risk is not known or exposure is not clearly known, and then just promoting, healthy lifestyle. And then one key condition is that it's important to counsel all patients after they're cured of hepatitis C that the hepatitis C antibody is positive lifelong for most patients. And again, that's just a marker for ever having been infected. And what we really care about in these patients in terms of monitoring for reinfection is making sure the RNA is not detected if ongoing exposures exist. So HCC screening is hepatocellular carcinoma screening or liver cancer screening. So all patients with advanced fibrosis, which is what we consider stage F3 or F4 pre-treatment, are recommended for liver cancer screening. This is lifelong. It's accomplished through a combination of ultrasound at a minimum, plus minus a serum blood test called the alpha-fetoprotein every 6 months. And this ultrasound can be ordered by anybody. It doesn't mean that a patient has to be seen by a specialist. There are in fact quite a few primary care physicians and physicians and providers working in non-specialty spaces that feel very comfortable monitoring for hepatitis, for hepatocellular carcinoma. And so it's just important that if you are going to refer them to a specialist, that this gets done, or if you are going to be following this patient long-term and they have established advanced liver disease, that this is also recommended to screen for liver cancer. And in conjunction with that, as I just mentioned, a lot of frontline healthcare providers in the community may refer patients with advanced liver disease, even if they have compensated cirrhosis, to periodically meet with a liver specialist to monitor for any signs or symptoms of liver decompensation. Some patients might have fibrosis improvement after their hepatitis C is cured. How do we know this? This is actually based on some data on biopsies pre and post treatment, as well as monitoring in other non-invasive ways for fibrosis, such as with serial fiber scans after patients have been cured. But I think the important thing to understand is that more than half, or more than 60%, in fact, will have histological changes in their liver that persist post-cure. And so while cure can lead to stabilization and even improvement in some patients in terms of liver fibrosis, a lot of patients will continue to have histological distortion and changes in the liver that persist after a cure. And current tools are not great at assessing who regresses fibrosis, who are the lucky patients in which fibrosis goes away after a cure, to determine who can safely stop liver cancer screening. And again, this is for patients with F3 or F4, what we call cirrhosis of the liver. So why do we care about hepatocellular carcinoma and what happens when we treat a patient with hepatitis C infection? So again, anybody with pre-treatment evidence of advanced liver disease or cirrhosis need to be screened. And this is because even starting with the older treatments, which we no longer use, the interferon-based treatments, in those patients who were followed after a cure and compared to those who were not cured, they found that there was a clear reduction over the 10 years of follow-up period after a cure in patients who were cured compared to those who were not in terms of liver cancer risk. But you see that the risk does not go to zero. And it's for this reason that it's really important to continue liver cancer screening. So really, SVR, a cure, reduces but does not eliminate the risk for liver cancer. So that was with the old interferon-based treatments. And what do we know about with direct-acting antivirals, the new antiviral treatments that are the mainstay of treatment? And there have also been studies published now looking at patients with cirrhosis who were followed after direct-acting antiviral treatment. This is a study looking at patients treated with sofosbuvir-based regimens who achieved a cure, and then compared to patients who had followed them for 85 weeks. And they were compared to patients who did not achieve a cure in green. And what you can see is that liver cancer-free survival certainly is improved in patients who achieve a cure, and there's less risk of decompensation, liver decompensation in patients who achieve a cure. But the risks don't go to zero, and the risks persist. So there's no untreated control group here, but the annual liver cancer incidence after cure with DAAs is lower than reported incidence with no treatment. Liver cancer incidence is much higher with decompensated cirrhosis. So you can see how these things of achieving a cure and not achieving a cure are linked to long-term outcomes when we're talking about liver function, decompensation of cirrhosis, and development of liver cancer risk. And we certainly have data from the Veterans Health Administration cohorts, so veterans, and this is large cohorts of patients that have now been followed. This is a study that was published on over 22,500 patients treated with direct-acting antivirals in the VA system, and looked at those who achieved no cure versus those who did achieve a cure. And you can see again, this is just highlighting what we've just mentioned, that the cumulative liver cancer incidence decreases, but it doesn't go to zero. So markedly lower. And DAAs also do not cause cancer, but it's important to keep in mind that in some practices, we are treating sicker patients. Now, the vast majority of patients who are younger are not likely to have advanced liver disease. So this is really a caveat in terms of thinking about patients who, again, in their pre-treatment assessment have evidence of advanced liver disease. This is probably going to be more likely to be found in your patients who are above childbearing age and above the age of 45, including in men, but something to keep in mind in terms of long-term post-treatment monitoring. So moving from post-treatment monitoring, I also wanted to spend some time on hepatitis C and pregnancy. So we know that the maternal hepatitis C prevalence at the county level in the United States has been rising over the years. And what we know is that we are definitely seeing more women of childbearing age who are now infected with hepatitis C infection. And when we look at race and maternal Hep C prevalence, there's also a clear signal here with seeing this increase most dramatically in non-Hispanic white women. So the AASLD and IDSA has put out some guidance in terms of testing for hepatitis C during pregnancy. So that's the American Association for the Study of Liver Diseases and the Infectious Disease Society of America. So it is recommended by AASLD, IDSA, and as well as the CDC as of 2020, that testing at the initiation of prenatal care is recommended to consider optimal opportunities for education, referral, and testing for infants that might get exposed to Hep C infection from moms who are carrying Hep C infection. And so again, as part of all prenatal care, all pregnant women with each pregnancy should be tested for Hep C infection, ideally at the initial visit. Early identification of Hep C infection in women living with Hep C who are pregnant and their exposed infants are really key for postpartum and really infant monitoring to make sure that hepatitis C evaluation and care are optimized. Women should be tested with a Hep C antibody test in pregnancy, and if positive, this should be followed with testing for Hep C RNA. So that is fairly standard, even if in women who are not of childbearing age and women who are not pregnant. So you want to do the antibody test, and really, if that's positive, ideally reflex to a Hep C RNA viral load. Hep C infected pregnant women should be linked to care so that antiviral treatment can be initiated at the appropriate time, which we'll talk about. Some key points regarding hepatitis C in pregnancy. Today, hepatitis C in pregnancy should be considered as a biomarker for opioid use disorder. And so it's really important in any women who are pregnant who are identified as living with hepatitis C to also ask them about opioid use, drug use, illicit substance use, in order to assess for opioid use disorder and engage them in medication-assisted therapy. Hep C treatment in pregnancy has not yet been approved with the direct-acting antivirals. There are no large-scale clinical trials evaluating yet the safety of direct-acting antivirals in pregnancy, although studies are ongoing currently. There was a small study evaluating the pharmacokinetics of one direct-acting antiviral that was sibosavir in pregnancy, which demonstrated 100% cure and no safety concerns. That's been published. And there's been an international case series of 15 pregnant women treated with ladipasvir sibosavir, in which 100% of them achieved a cure, and there were no early safety concerns in women or their infants that were monitored. So currently, there isn't data on the use of pan-genotypic regimens during pregnancy, although there's no reason to think that outcomes and efficacy should be any different. Despite the lack of recommendations, treatment for hepatitis C can be considered during pregnancy on an individual basis after a patient-physician discussion about the potential risks and benefits. So these are the recommendations from the AASLD and IDSA. For women of reproductive age with known Hep C infection, go back a couple of slides. Antiviral therapy is recommended before considering pregnancy. So the ideal time to screen a woman is before getting pregnant. And if they're known to have hepatitis C, then to consider antiviral therapy before considering family planning, if that is at all possible. And so it's really when it's practical and feasible to reduce the risk of hepatitis C transmission to the baby. And in terms of recommendations regarding breastfeeding and postpartum care for hepatitis C infected women, breastfeeding is not contraindicated in women who are living with hepatitis C infection, except when the mother has cracked, damaged, or bleeding nipples, or in the context of HIV co-infection because of the increased rates of transmission. And women with hepatitis C infection should have their Hep C RNA reevaluated after delivery to assess for spontaneous clearance, which does on occasion happen. So what about this idea of treating women in pregnancy? So I've mentioned that the direct-acting antivirals in the United States have not yet been approved for treatment in pregnancy, but this needs to be an individual discussion. There is some very limited data, additional data that will be coming down the pipeline in terms of larger clinical trials looking at safety and efficacy. So women who become pregnant while on direct-acting antiviral therapies is another scenario. With or without ribavirin should discuss the risks versus benefits of continuing treatment with their physicians. Ribavirin is not commonly used in the regimens we're giving patients, but there are some patients who are getting it if they've been treatment experienced and also might have more advanced liver disease. And this is a pregnancy class X drug, and it is strongly contraindicated in pregnancy because it is known to be teratogenic to babies. And in addition to the risk for teratogenicity, persists for up to 6 months after ribavirin is stopped. So again, in the small group of women of childbearing age who are on ribavirin-based treatments or recently treated with ribavirin-based regimens, it's recommended that pregnancies do not happen for 6 months until after stopping ribavirin to make sure it's been cleared out of the system. And this also applies for men in terms of contribution to family planning. So what about vertical transmission of hepatitis C from mother to child? Well, vertical transmission is a leading cause of hepatitis C infection in children. 1/3 to 1/2 of mother to child transmission, that's what MTCT stands for, of Hep C occurs in utero prior to the last month of pregnancy. Remainder occurs in the last month of pregnancy or delivery. There's been a meta-analysis that was published several years ago examining rates of vertical transmission of hepatitis C stratified by whether women were co-infected with HIV. And we certainly know that based on this pooling of 17 studies, women with chronic Hep C who were HIV negative had a very low risk of transmission to the baby of around 4 to 6%. So 5.8% is the number they had in the study. 4 to 6% is what we counsel women who are not HIV infected. The risk of vertical transmission goes up in women who are also co-infected with HIV. And the pooled analysis here showed a doubling of transmission rates, closer to 11%. So how do we assess for mother to child transmission? So we have the birth of the baby. So we know the mom's status, the mom is infected. We have the birth of the child. And at 2 months is the earliest time that Hep C RNA can be done to know whether or not it's reliably detected in a newborn. It's recommended that testing is done again at 18 months with an antibody to really establish whether or not there was mother to child transmission. And then based on that, at 3 years, Hep C RNA testing is recommended for any infant who is Hep C antibody at 18 months for confirmation. There's a lot of immunological changes, passive immunity that goes away during this time course to really get a good understanding of whether or not a toddler has true hepatitis C infection. And treatments are now approved with select DAAs in as young as children that are 3 years of age. So this is really the earliest time point for Hep C treatment initiation. But it's really critical that all women who are living with Hep C, who are pregnant and have a baby, that the baby gets monitored for this mother to child transmission along this pathway, which most pediatricians, if they're aware of the mother status, can do. Now, what are the pros and cons of treatment with direct-acting antivirals during pregnancy? Well, a maternal cure, while engaged in pregnancy care, pregnancy for a lot of women of childbearing age represents a time when they have access and have insurance, health insurance, and are engaged in a different way with healthcare oftentimes. There's a possibility of decreasing the risk of mother to child transmission, even though that risk is small, particularly in HIV negative women. Maternal treatment while under insurance coverage is feasible. We all know that the direct-acting antivirals need to be approved by insurances in order to treat our patients. And this can then have a broader impact and decrease in community transmission, because again, it's really important to think of women childbearing age with hepatitis C infection, particularly in pregnancy, as a biomarker for opioid use disorder. And so there may be other community transmission risks in that context. And there's a potential decrease in Hep C associated adverse pregnancy outcome. And there's a question mark there, and I'm going to go through some data. What are some of the cons that folks have raised? The human safety in pregnancy of direct-acting antivirals has not been maybe fully established, although additional studies are being done to hopefully get us to a better understanding. Safety during breastfeeding has some limited data, although safety not robustly established. More established data for treatment prior to pregnancy or children starting at the age of 3, and difficulty in accessing DAA therapy in time prior to delivery. So in a lot of places where you practice, that time to approval can be happening along the time course that's paralleling progression in pregnancy. And so that timing is important. And what you certainly want to avoid is starting treatment, losing insurance, and not being able to complete treatment. So it's something to keep in mind. And then finally, cost effectiveness has not been well established, although I think we will have some data soon on that. So what is the effect of Hep C infection on pregnancy? Hep C may have a negative effect, but it's really difficult to tease apart from effects of associated factors. So this can include effects related to opioid use disorder, injection drug use, overdoses. And so this, there were a couple of meta-analysis, one meta-analysis of over 4 million women, which included over 5,000 with Hep C infection, as well as a Swedish birth cohort registry study of over 1 million women, which included over 2,000 births in women who were Hep C infected. And you can see that there's a small increased risk of preterm birth in women living with Hep C who are pregnant in terms of birth and baby outcomes. Also an increased risk of intrauterine fetal growth restriction and lower birth weight has been established as well. The Swedish registry also highlighted that there could be an increased risk with mortality in terms of late neonatal death, and also showed preterm birth was associated in women living with Hep C infection. So multi-observational US study to assess outcomes in pregnancy women with Hep C and their infants was launched in 2012, and some data has been presented that looks fairly promising with similar outcomes. So why consider, again, antiviral therapy during pregnancy? And I think I can't overstate this enough. There's the potential to reduce the risk of mother-to-child transmission, although that risk is fairly small in HIV uninfected women, but it exists. It's between 4 and 6%. Pregnancy, again, I think this is the real thing to think about, is often a time when women have health insurance and are engaged in healthcare. And so this really presents itself as an opportune time to treat Hep C concurrent with pregnancy care. And I think we're going to see more treatment likely happening based on the additional data that seems forthcoming from some of the clinical trials if the safety and efficacy standards are met. And really, again, this provides an opportunity to cure hepatitis C in women with higher risk behaviors to prevent transmission to others, including injecting partners. So I think this gets to the, the potential to reduce community transmission piece. So this kind of summarized what I showed you already, that in HIV negative women, the risk of transmitting Hep C infection to the newborn is between 4 and 6%, and in women, it's between 10 and 11% if they have HIV infection. Now, the Society of Maternal and Fetal Medicine also has some recommendations regarding prevention of mother-to-child transmission, and I've also included the grade of evidence in terms of the recommendation strength. So, I think there are a lot of kind of folks that have delineated practices that they think might be better. And this is kind of like what the society was trying to address in a more standardized way. So amniocentesis is recommended over chorionic villus sampling, given the lack of data on the latter. May not be that actually one is a higher risk than the other, but we have more data in terms of safety and low risk of transmission with amniocentesis. They recommend against C-section solely for the indication of Hep C, and that the C-section mode of delivery should really be dictated based on what's best for the mom and child outside of the Hep C status. They also recommend that obstetric care providers avoid internal fetal monitoring, prolonged rupture of membranes, and episiotomy in managing labor in Hep C positive women, given the risk of promoting mother-to-child transmission in these settings. And they recommend that providers not discourage breastfeeding based on positive Hep C infection status. So women should be encouraged to breastfeed even if they're living with Hep C infection in that postpartum period. So in mother-to-child transmission, the most common cause of hepatitis C in children. So again, 25 to 40% of infants clear hepatitis C spontaneously, believe it or not, in those that get transmission by 2 to 3 years of age. The impact of Hep C in children on quality of life, there's been some studies that showed reduced physical functioning, executive functioning impairment in up to 20% of children, and worse cognitive functioning versus children without Hep C. And higher rates of cirrhosis in children who acquire Hep C through mother-to-child transmission. Some of this might be shifting though, because now we have direct-acting antivirals that are approved down to the age of 3, which we didn't when most of these other studies were conducted. So children had to wait till they became adults, essentially, to be offered treatment. And hepatocellular carcinoma screening is the second most common hepatic malignancy in children. This is not all driven by hepatitis C infection, obviously, but it's something to keep in mind. So moving from Hep C infection, wanted to kind of end this third part of this talk today, really discussing this concept of hepatitis B and C co-infection and the small risk of reactivation. So to help put things in a global perspective, when we talk about hepatitis B versus hepatitis C, there's a lot more hepatitis B infection globally. 200 and close to 60 million people in the world are living with hepatitis B infection chronically. And compared to Hep C, you see that it's about a little over 70 million people living with hepatitis C. Viral hepatitis remains a major source of mortality in the United States. So here is data up through 2016, looking at causes of cirrhosis, as well as risk of liver cancer. So this is really Hep C drives still most of it, although you see with liver cancer, you see more Hep B as well. So as I just mentioned, 257 million people globally are living with hepatitis C infection. And 68% of these people living with hepatitis B infection are located in Africa and the Western Pacific region. 2.7 million are co-infected with HIV. Most infected persons were born before hepatitis B vaccine was widely used in infancy. So here in the United States, that happened in 1991. And so hepatitis B remains a leading cause of cirrhosis and liver cancer worldwide. And up to 50% of liver cancer associated Hep B happen in the absence of cirrhosis. So this is a unique liver disease in that it doesn't require cirrhosis in terms of leading to a risk of liver cancer. And Hep B is really second to tobacco use in causing cancer deaths. And it's 50 to 100 times more infectious than HIV in terms of the amount. So when you think about the geographic distribution of Hep B, as I just mentioned, Africa and the Western Pacific region have the highest rates of hepatitis B. More than 8% or higher of populations in these regions have Hep B infection. And that's compared to what we see nationally as a trend, less than 2% in the United States. But we know that still targets for treatment and diagnosis of Hep B remain really low. So we're not doing a great job in the United States, as well as elsewhere in terms of testing and treatment. And in terms of the major modes of transmission, mother to child transmission remains a very, very common cause of transmission. So more than 50% of cases globally are from mother to child transmission. Also horizontal within the household during early childhood when the immune system of children are not yet mature enough to have high rates of clearance spontaneously. And unfortunately, globally, we still see a lot of iatrogenic causes through healthcare, and that includes dental care, through reuse of non-sterilized needles, syringes in resource poor areas, and contaminated blood products. That has improved with vaccine scale-up and testing of blood. And then other traditional medicine practices, although the contribution in terms of amount is unclear. And then in non-endemic countries, which is like the United States, unprotected sexual intercourse and IV intravenous drug use are now really been the leading causes for Hep B infection here. So some key points in terms of Hep B infection that make it somewhat unique. Unlike Hep C, hepatitis B, the virus actually incorporates into the host DNA. And not everybody's recommended for treatment. And so treatment's really recommended in patients who have signs of developing fibrosis. And treatment is aimed at viral suppression. There are curative treatments for Hep B trials that are ongoing right now. But currently, treatment is lifelong, and once it's started, it's continued because all it does is suppress the virus, and once you usually withdraw treatment for most patients, the virus will come back. Treatments are safe and effective, and as I just mentioned, there are a number of curative therapies for Hep B being studied currently. So the outcome of hepatitis B infection is largely influenced by age of transmission. So the younger the age, so neonatal infection has the highest rates of chronic infection. And I just mentioned that more than 50% of cases globally are from mother to child. And so when you acquire this at the time of birth in utero or during the delivery period, and even in early childhood, your rates of developing chronic Hep B are quite high, more than 90%. This is very different than in adults, where if you get this largely through unprotected sexual intercourse and drug use behavior because of blood-blood transmission, 85% will go ahead and clear it spontaneously because we have healthy, robust immune systems that clear the virus and prevent it from integrating into our host DNA. And so for that reason, that age at which this virus is acquired really influences risk of developing chronic infection with Hep B. I think one thing to keep in mind is that we've had a very safe and effective vaccine for hepatitis B, and that's why we recommend all patients, even living with Hep C, get screened for Hep C because of Hep B because of one, shared routes of transmission, but two, to look for opportunities for prevention through vaccination. Because again, prior to 1991, we were not immunizing all infants born in the United States. So there are a lot of people who were born before that time period who may be at risk and could be protected lifelong through a vaccination. So hepatitis B can cause chronic liver disease. And what that translates to is acute infection can go on to become chronic infection, and that's largely influenced by the age at which you acquire the infection. And that can then increase your liver cancer risk independent of cirrhosis. And then certainly with cirrhosis, you can have a higher risk of liver failure, need for liver transplant, and or death. And what's been happening here more recently over the last several years in the United States, we've certainly, along with a rise in Hep C cases nationally paralleling the opioid epidemic, we've seen a dramatic increase in the number of hepatitis B cases. So as of 2018, there have been over 3,000 reported acute cases of Hep B, and there are an estimated 21,000 estimated acute infections. This represents over 2014 to 2018, an 11% increase in acute cases. And more than 1/2 acute Hep B cases were among persons between the ages of 30 and 49 years. And were due to low vaccination rates and this parallel between risk factors with opioid use disorder. And up to 70% of chronic hepatitis B infections, it's really important to keep this in mind, are not in US born populations, but they're actually in non-US born populations. So regions of the world that I just mentioned, including East Asia and Africa, where the rates of Hep B infection are much higher. So the great shoulder of this burden of hepatitis B infection in the United States is still in our immigrant and select immigrant populations where Hep B infection is much higher. So this just shows you the reported and estimated cases to the CDC in terms of Hep B cases over the last 8-year period between 2010 and 2018. And you can see that proportions that are disproportionately impacted include, in terms of acute infection, people who inject drugs, and in chronic infection, it's still largely Asian, Pacific Islander, Black, non-Hispanics. And the current challenges include injection drug use and getting people's status known through testing and offering vaccination. So there's very low adult vaccination rates. And chronically, in terms of really still trying to work to get perinatal transmission to as close as 0 or 2-0 if possible. There's still a lack of awareness of infection. It's a silent infection like Hep C for many until complications related to liver cancer or liver failure or cirrhosis develop. And so it's really important to proactively be having strategies to test and link to care patients or populations who are at risk for living with hepatitis B. And while we don't have any curative treatments yet, there is hope that we will in our lifetime with some of these new trials that are being done. So this is just to show you kind of the distribution of acute Hep B. This is from an MMWR report from the CDC, looking at data of acute Hep B infection in Kentucky, Tennessee, and West Virginia, and breaking it down by non-urban and urban areas. And you can see that this rise, again, like with Hep C infection and in terms of the disproportionate burden of opioid use disorder in rural populations, has really largely been seen mostly in non-urban populations. So the US Preventative Services Task Force recommends screening for high-risk people and who are high-risk persons, so people born in regions where the prevalence of Hep B infection is greater than or equal to 2%. So that's anything in color here. So if you're born in one of those regions, you should get tested at least once in your lifetime. And then US-born persons not vaccinated as infants whose parents were born in regions with a high prevalence, so greater than or equal to 8%. So any place if you had a parent born in red here. And additionally, patients who should be screened for Hep B include persons in those high endemic areas, US-born children of immigrants who had a parent born in one of the high-risk areas, household and sexual contacts of a person who has hepatitis B, persons who have injection drug use, persons with multiple sexual partners and history of STIs, men who have sex with men, inmates and correctional facility residents, individuals with chronically elevated ALT, AST, individuals infected with HIV or Hep C because of shared routes of transmission, and then also additional categories including all pregnant women, patients undergoing dialysis, patients who are immunosuppressed, and infants born to Hep B carrier mothers. So how common is Hep B infection in the United States? More than 90% of cases in the US occur in immigrants from those endemic parts of the world. Most new Hep B cases of acute infection in the United States are from sexual transmission or injection drug use. And 2,000 to 4,000 deaths occur annually from complications of chronic Hep B infection, decompensated cirrhosis, and liver cancer. 15% of liver cancer cases, even in the United States, are from Hep B infection. So how do you diagnose hepatitis B infection? Well, there are blood tests to screen a person for hepatitis B. And in patients who are living with Hep C, it's recommended that all 3 of these tests are checked. A Hep B surface antigen, that's the test that's really the marker for active infection or chronic infection. Hepatitis B surface antibody, which is a marker for immunity, either through vaccination or prior infection. And the Hep B antibody to core total is really going to be a marker for previous exposure infection, very rarely can be a false positive. There is a test called the Hep B IgM to the core antibody, and the only time to check that is in a patient in whom you suspect acute infection. So someone who's coming in with a viral prodrome syndrome, somebody with elevated liver tests that are otherwise unexplained, somebody with jaundice, that should all signal checking this IgM test. That's the only scenario in which you'll be looking for Hep B infection. And many people with acute infection are asymptomatic. So really these top 3 tests, the Hep B surface antigen, the Hep B surface antibody, and the Hep B core antibody are the most important screening tests and should be checked on every person living with Hep C prior to treatment. If a person does have Hep B infection, it's important that they get additional tests. And these are the additional tests: the Hep B E antigen, the Hep B E antibody, and the Hep B DNA or virus level. and about 30 to 40% have active hepatitis that meet criteria for antiviral treatment for Hep B. There are more than 6 treatments that are now approved for hepatitis B treatment. There's one treatment actually that's not on here, which is tenofovir alafetamide, which was approved in 2017. So that's the 7th one that should be listed here. And the top line treatments are entecavir, tenofovir alafetamide, and pegylated interferon. Those are first line preferred treatments. And what about co-infection? How common is co-infection with hepatitis B and hepatitis C? This really depends on the patient population and the regional prevalence that you're practicing in. In the literature on the whole, 10 to 15% of Hep C infected patients are co-infected with Hep B, and up to 30% in some settings. And again, 5 to 20% of Hep B patients are co-infected with Hep C. And the important thing just to keep in mind is that there's shared routes of transmission. So blood-blood transmission can not only put you at risk for Hep C infection, but can also put you at risk for Hep B infection. And that's why it's important to understand that there is this chance to have both viruses present in a given individual. And hepatitis B and hepatitis C dual infection, what are the issues to think about? Well, if you have both of these viruses, you're more likely to develop accelerated liver disease. And so these patients really need to get prioritized for treatment because they can develop cirrhosis in half the amount of time as somebody who just has Hep C infection. And then I'm going to talk a little bit about the risk of reactivation to Hep B with Hep C treatment. So there are viral interactions in patients who have Hep B and Hep C that are naturally occurring for patients who have both of these viruses. There can be direct inhibition of Hep C to Hep B replication, increase in available replication space after one virus is eradicated. So you treat the Hep C becomes undetectable, and then it allows for more really replication space. So the Hep B then ramps up in terms of the viral load and can cause a flare or reactivation. And then finally, the third theory is that there's a loss of host immune responses to one of these viruses, usually Hep B, or production of an immune inhibitory signal. And this can improve replication over the other. So you might have one virus in a patient who's infected with both dominate, meaning it has a higher viral load. And the goal would be to think about treating all of these patients. So what is this concept of Hep B reactivation, and why do we care about it in patients living with Hep C? Hep B reactivation is a clinical syndrome. It's characterized by a sudden increase in Hep B replication due to a loss of immune control. So who can get this? Anybody who's surface antigen positive and core antibody positive, or even if you're surface antigen negative, meaning you don't have chronic Hep B infection, but you've had Hep B in the past, so you have your core antibody that's positive. Either two groups of these patients are at risk for reactivation. Reactivation is defined as more than a 1 log increase in your Hep B DNA in the blood, or a return of Hep B DNA viremia in a patient with undetectable Hep B DNA at baseline. And this may include reverse seroconversion, so you can have return of surface antigen in somebody who's been surface antigen negative, meaning they didn't have chronic Hep B. And the other thing to keep in mind is that Hep B reactivation can really manifest along a wide clinical spectrum. It can be silent, maybe a small elevation in the viral load without overt even liver test elevations or inflammation. And kind of in the middle of that spectrum would be a hepatitis, liver tests are elevated, patients might have symptoms, and an elevated viral load. And at the other end of the spectrum is fulminant hepatic failure, has been seen, reported. We've all seen cases of it, unfortunately, and it's unfortunate because it can be prevented. So hepatitis B reactivation in the context of Hep C is an unwanted effect of Hep C treatment. So there have been databases created to try to identify cases of Hep B reactivation in patients who are undergoing treatment for Hep C with direct-acting antivirals. The FDA now requires a boxed warning to check everybody for Hep B prior to initiating them with Hep C treatment. And this is based on 29 cases identified across the globe, 5 in the United States, 19 in Japan, and 5 in other countries, where 3 patients in the context of getting treated for Hep C without knowing their Hep B status, 3 patients decompensated in terms of liver disease, 2 out of 3 actually died, and 1 out of 3 required a liver transplant. The mean time to reactivation was between 4 to 8 weeks, so that was 53 days, and there was no specific DAA regimen that was the culprit, and no specific genotype that put patients more at risk. And so this is really important to have an awareness about, and test all your patients with Hep C for Hep B. Now, the theories around reactivation have to do with core Hep C core protein interfering with Hep B gene expression, increased available replication space, as I just mentioned, and Hep C can induce an interferon abundant state that inhibits Hep B replication. And so once the Hep C is eradicated and gone, the interferons relax, and this allows the Hep B to ramp up. So there have been now a number of studies looking at DAAs compared to the old interferon treatments in terms of risk of reactivation. The pooled Hep B reactivation rate was around 14%. It was 14% in interferon and 12.2 in interferon-free DAAs. It occurred sooner with DAAs. So just something to keep in mind. And another meta-analysis looking at 17 studies, including 242 with chronic Hep B and over 1,300 with resolved Hep B. The risk of reactivation was 24% in those with untreated chronic Hep B infection. So the patients who are surface antigen positive are way at higher risk. So people who are co-infected. And 1.4%, so that's very small, 1.4% of people who had just core antibody positive. So they had been infected in the past. So risk of Hep B reactivation related hepatitis was 9% with chronic Hep B and no Hep B related hepatitis with resolved infection. So the most important take home point here is to be proactive. You have to look for it. Prevention of Hep B reactivation is 100% achievable. And it's really important because the worst case scenario is somebody goes into liver failure and can die from it if we don't look for it. So in all patients living with Hep C, it's important to screen them for hepatitis B with those 3 blood tests, stratify the risk based on the virological data. Now, Hep B reactivation can also happen outside of Hep C treatment with other immunosuppression, which we won't get too much into, and it's important to tailor the management. So how do we prevent it? Test all patients initiating Hep C treatment for hepatitis B with these 3 tests, the Hep B surface antigen, the Hep B core antibody, and the Hep B surface antibody. If the surface antigen is positive, those people are co-infected. They should get treated for Hep B while they're on Hep C treatment or monitored closely. And in those who have very low Hep B viral load, they can be monitored for reactivation with just blood tests. And if you do have a patient who has Hep B and Hep C, it's important to start Hep B treatment at the same time or before you start them on Hep C treatment. And you can treat both viruses at the same time until they are cured. And then if you do plan to stop Hep B therapy after they're cured of their Hep C, it's important to monitor closely for a hepatitis B flare. And this is a slide just to show you that Hep B infection doesn't really impact your selection of Hep C medications. So these are the Hep B treatments that I just mentioned that are most commonly used. And there isn't too much of drug-drug interaction, although potential with ladipavir, sofosbuvir, velpatasvir, and tenofovir, which can be kind of circumvented by either giving them entecavir or tenofovir alafenamide. So I'll just conclude here, post-treatment monitoring with liver cancer screening is recommended for all patients with advanced fibrosis prior to Hep C treatment. A diagnosis of Hep C in pregnancy is a biomarker for opioid use disorder. And so that should make you pause and also discuss opioid use practices and engagement around medication for opioid use disorder in that setting. The optimal timing for Hep C treatment should be tailored to the individual patient. So although robust treatment and pregnancy data is lacking, we hopefully will have more soon, and it all needs to be tailored to the potential pros of treating a woman during pregnancy, including things like having health insurance and engagement in healthcare. And then finally, all patients should be screened for Hep B prior to initiation of Hep C infection, given the risk of co-infection and risk of reactivation. So I'll end there and thank everybody for joining. All of these slides will be available for download and also for CME credit on our website. Thank you.